If you take a blood pressure pill every morning, I want you to imagine something unsettling. Tomorrow, before you swallow that tablet, pause for 5 seconds and ask yourself one brutally honest question. Do I actually understand what this drug is doing inside my body right now? Not the slogan on the label, not the rushed explanation from the clinic, not the vague comfort of knowing it is for pressure. I mean, truly understand it. What it changes, what it protects, what it strains, what it can hide, and what it might whisper before it ever screams. Most people cannot answer that question with confidence, and that silence is where trouble begins. These are not harmless little helpers. Amlodipine, Losartan, and Lisinopril are powerful medicines that change blood flow, vessel tension, kidney chemistry, and the workload placed on your heart every single day. They can protect you from stroke, heart failure, and kidney damage when used correctly. They can also confuse you, frighten you, and in the wrong circumstances, quietly push your body toward danger if you do not know what signals to watch. That is not meant to scare you, it is meant to wake you up. I have seen too many smart, careful adults take these medications on autopilot. They line them up in a pill organizer, swallow them faithfully, and assume that routine equals safety. But routine without understanding can be risky, because the body does not care whether you are disciplined. It responds to physiology, not good intentions. A symptom you dismiss as aging may be the medication. A reaction you blame on poor sleep may be your blood pressure dropping too far. A product sold as healthy may quietly interact with your prescription in a way nobody warned you about. That is why today matters. By the time we are done, you are going to understand these 3 medications in a way that is practical, memorable, and immediately useful. You will know why they are not interchangeable. You will know which side effects are common, which ones deserve a phone call, and which ones should never, ever be ignored. Most importantly, you will know how ordinary situations like dehydration, pain relief, diet changes, or a stomach bug can completely change the way these drugs behave inside your body. But to understand that, we have to begin with a man I will call George. He was 74, methodical, intelligent, and proud of the fact that he never missed a dose of anything. His daughter had arranged his medications in a weekly organizer, and George treated that organizer like a contract. Monday meant Monday, Thursday meant Thursday, no mistakes, no excuses. When his doctor added amlodipine to his regimen, George barely reacted. Another blood pressure pill, he thought. Different name, same job, end of story. Except that was not the end of the story. 3 months later, George could not fit comfortably into the shoes he had worn for years. By late afternoon, his socks were cutting deep marks into his ankles. His feet looked thick. His lower legs felt heavy, almost dense, as though walking required more effort than it should. He started cutting his walks short. Then he started skipping them. Then he began sitting more, worrying more, searching more. One evening he told his son, in a voice that was half embarrassed and half frightened, that he thought his circulation might be failing. That fear changed the way he lived. He stopped going to the park. He stopped meeting friends for coffee because the walk from the parking lot felt uncomfortable. He spent more time reading about heart failure online and less time moving. And the cruelest part is that George was not being dramatic. He was interpreting a real physical change with the wrong mental map. Nobody had explained to him that amlodipine, Losartan, and Lisinopril may all lower blood pressure, but they are not the same kind of medication. They do not act on the same system. They do not create the same side effects. They do not send the same warning signs. That difference is everything. Amlodipine belongs to a group called calcium channel blockers. It lowers blood pressure by relaxing blood vessels, making it easier for blood to move forward. Lisinopril is an ACE inhibitor. It works on a hormone system that tightens blood vessels, blocking part of that tightening signal. Losartan is an ARB, which acts on that same overall pressure system from a different angle. 3 drugs, 3 mechanisms, 3 distinct patterns your body may show you when something is not quite right. Once you understand that, your symptoms stop looking random. George's swollen feet were not proof that his heart was shutting down. In many people, ankle or lower leg swelling is a known effect of amlodipine. It happens often enough that it should be discussed before the first tablet is ever taken. Yet many patients learn about it only after they are scared by it. George eventually did what many people delay for far too long. He mentioned the swelling. The medication plan was reviewed. The pattern suddenly made sense, and within weeks he felt as if somebody had handed him part of his life back. That is why the safest patient is not the one who swallows a pill without question. It is the one who understands the pattern before the pattern appears. And in the next few minutes, one seemingly minor symptom will show you just how badly a misunderstood medication can distort everyday life completely. That is the first lesson I want burned into your memory. The name on the bottle is not just a label, it is a category, and the category tells you the pattern. If you miss that pattern, you can spend months fearing the wrong problem, ignoring the real one, or making a decision that feels logical but turns out dangerous. And the next warning sign is one of the most misunderstood of them all. Let's stay with amlodipine for a moment, because the swelling it can cause is one of the most common reasons people grow anxious, frustrated, or quietly non-compliant. The misunderstanding starts with a simple assumption. People see puffy ankles and think, I must be retaining water. Then they jump to a second assumption. Maybe my kidneys are struggling, or worse, maybe my heart is failing. In many cases, that interpretation is simply wrong. Here is the simpler version of what can happen. Amlodipine relaxes the small arteries well. Blood enters those tiny circulation beds more easily. But the veins do not relax in exactly the same way. So the balance between blood flowing in and blood flowing back can shift. Pressure builds in the small vessels near the ankles and feet, and some fluid moves out into the surrounding tissue. The result is familiar to anyone who has experienced it. Shoes feel tighter. Socks leave ridges. By late afternoon, the legs feel heavy and slightly overfilled. That matters because a side effect is not just about biology, it is about the decisions that follow. Some people see that swelling and stop the drug on their own. Their reasoning sounds sensible. My legs got worse after the medication, so I removed the cause. But blood pressure drugs are not like turning off a lamp. Remove them suddenly without a plan, and blood pressure can rise quietly again while you convince yourself you solved the problem. Other people do the opposite. They stay on the medication but start drinking less water because they assume the swelling means too much fluid. That move can backfire, especially in older adults, because dehydration changes the way the body tolerates blood pressure medication. Then there is the third group, the silent endurers. They accept the swelling, move less, elevate their feet when they can, complain to nobody, and gradually surrender pieces of daily life that matter. The walk becomes shorter, the errands become fewer, the social events become optional. Over time, a manageable side effect can steal far more than comfort. It can steal confidence. The point is not that all swelling is harmless, it is that swelling needs context. If one leg suddenly becomes far more swollen than the other, if there is pain, redness, shortness of breath, chest discomfort, or rapid worsening, that is a different story, and it needs urgent evaluation. But when both ankles slowly puff up over weeks after starting amlodipine, the possibility of a known medication effect should move high on the list. That is why silence is the enemy. A doctor cannot solve a side effect nobody mentions. Now let's turn to lisinopril, because this drug carries one of the most notorious delayed reactions in blood pressure medicine, the dry cough. Not the deep chest cough of an infection, not a loose productive cough. A stubborn, scratchy, almost teasing irritation that sits in the back of the throat and keeps returning. It can show up during the day, but for many people it becomes especially maddening at night. They clear their throat, they sip water, they try lozenges, they blame dust, allergies, reflux, or weather. And because the cough often begins weeks or even months after the medication starts, they rarely connect it to the pill. I once heard a woman describe it perfectly. She said it felt like her throat had one unfinished sentence trapped in it all day. That is how sneaky medication symptoms can be. They do not always arrive with drama. Sometimes they arrive with annoyance, and annoyance, repeated often enough, can change a person's mood, sleep, patience, and quality of life more than people realize. So imagine a woman I will call Margaret, 71, active, practical, happiest when she had dirt under her fingernails from time in the garden. Her cough began in late spring, exactly when pollen counts were climbing. To her, the explanation seemed obvious: seasonal allergies. She bought antihistamines. She kept windows closed. She tried honey, humidifiers, and herbal teas. A chest x-ray was clear. Months passed. The cough stayed. Night after night, it stole rest in small pieces. She grew tired without looking dramatically ill, which is often the hardest kind of suffering for other people to appreciate. When her medications were reviewed carefully, one detail changed everything. She had started Lisinopril months before the cough appeared. The timing had never seemed close enough to matter, so nobody had focused on it. Once the possibility was recognized and her prescriber discussed an alternative, the cough faded. Not slowly over years, not after endless remedies. It faded once the cause was understood. This is why categories matter. Lisinopril lowers blood pressure by blocking an enzyme in a system that tightens blood vessels. That same mechanism is why it belongs to a family known for cough in some patients. Losartan works on the same general pressure pathway from another step, which is one reason people who cannot tolerate ACE inhibitor cough are sometimes switched to an ARB instead. But with lisinopril, there is another warning that is far more important than cough, and this is the moment where a nuisance ends and an emergency begins. If swelling affects the lips, tongue, face, or throat, especially with trouble swallowing, hoarseness, or difficulty breathing, that is not something to watch until morning. That demands urgent medical help immediately. Rare does not mean impossible, and the people harmed most by rare reactions are often the ones who assumed rare meant safe to ignore. Here is the rule. If a symptom lingers, interrupts sleep, changes mobility, or alters daily routine, it is important enough to mention. And the next problem we need to discuss begins so quietly that many people miss it until danger is close. Because the next danger is even quieter. It can begin in a kitchen, at a grocery shelf, inside something marketed as healthy, and it may have no symptoms at all until the heart notices first. Losartan is often described as a straightforward blood pressure medication, and in many ways it is. It blocks the action of angiotensin II, a natural chemical that tightens blood vessels, allowing blood to flow more easily and the heart to pump with less resistance. That is the clean medical explanation. But real life is never as clean as pharmacology. Because once a drug enters a person's daily habits, the story is no longer just about the drug. It becomes about the food, the supplements, the over-the-counter products, the weather, the illness, the routines, and the assumptions surrounding it. One of the quietest risks with losartan, and sometimes with lisinopril as well, involves potassium. The body needs potassium. It helps muscles contract and supports the electrical rhythms that let the heart beat correctly. The problem is not potassium itself. The problem is imbalance. Losartan and lisinopril can make high potassium more likely, which is why people taking them are told to be cautious with potassium supplements and salt substitutes that contain potassium. And here is where everyday health advice can collide with medication safety. A person is told to cut down on sodium. They go shopping. They see a salt substitute marketed as a smarter choice. It sits there with clean packaging and promises of better living. What many people do not realize is that these products often replace sodium with potassium. That means a person can unknowingly sprinkle extra potassium over breakfast, lunch, and dinner while already taking a prescription that changes how the body handles it. The danger is not always dramatic at first. High potassium can be subtle. It may show up as muscle weakness, unusual fatigue, cramping, tingling, or a strange fluttering sensation in the chest. Sometimes there are hardly any clear symptoms at all until the level becomes serious enough to affect the heart's electrical system. That is what makes it dangerous. People tend to respect what feels severe and dismiss what feels vague. Potassium problems often begin in the vague zone. This is why I want you to picture a completely ordinary scene. A man stands in his kitchen, shaking a generous layer of salt substitute over scrambled eggs because he is trying to be healthier. He feels responsible, disciplined, proud even. Meanwhile, the medication in his bloodstream is already pushing his potassium balance in the same direction. Nobody told him the two choices belong in the same conversation. He is not careless, he is uninformed. And uninformed patients can be incredibly diligent while still moving toward preventable trouble. The same issue can hide in supplements and convenience products. Potassium tablets are obvious, but powders, hydration mixes, and certain meal replacements can also add more than people realize. The larger lesson is simple. Anything you start regularly putting into your body belongs in the conversation if you take a blood pressure medication that affects kidney handling of electrolytes. Prescription bottles do not live in isolation from grocery carts. Now we need to widen the lens even further, because there is a scenario that catches older adults off guard again and again. It is not a dramatic diagnosis. It is not a hospital event. It is not a rare disease. It is a stomach bug. A few days of vomiting, diarrhea that will not quit, fever, sweats, poor appetite, and a body that is losing fluid faster than it can replace it. Under those conditions, the same dose of lisinopril or losartan that worked perfectly in a well-hydrated body can become far less forgiving. Both medication families are commonly included in sick day guidance because dehydration can increase the risk of low blood pressure and acute kidney injury. Think about how easy it is to miss this. The pill has been safe for months, maybe years. So when illness hits, people keep taking everything exactly the same way because consistency has been drilled into them. But illness changes the rules. A body that is short on fluid does not process stress the same way. Kidneys can become more vulnerable. Pressure can fall too low. Dizziness can turn into faintness. Weakness can become alarming quickly. That is why sick day plans matter. If you take medicines like lisinopril or losartan, you should know in advance what your prescriber wants you to do if you cannot keep fluids down, develop repeated vomiting or diarrhea, or become severely dehydrated. Some guidance advises temporarily pausing certain medicines during significant dehydrating illness and restarting once you are eating and drinking normally again for a day or two. But that plan should come from your own clinician, not guesswork in the middle of a miserable night. When dehydration enters the picture, everything tightens. Less circulating fluid means less room for error, less kidney reserve, and less forgiveness from medications that normally feel routine. That is why even a short illness can become a test of preparation. Do you know which pills to ask about? Do you know when to restart them? Do you know what symptoms mean your body is no longer compensating well? People who know those answers do not become invincible, but they become far less likely to drift into preventable trouble while assuming they are simply waiting out a bug. The question is not whether illness will ever interrupt your routine. It will. The question is whether you will recognize that interruption as medically important before dizziness, faintness, or kidney stress forces the issue. Most people do not realize the clock starts ticking long before an emergency room visit becomes necessary. And that is where the quietest mistakes become the costliest. And there is another twist most people never see coming. Sometimes the medication itself is not the only threat. Sometimes it is the completely ordinary pain reliever pulled from a drugstore shelf that turns an already stressed kidney into the center of a much more dangerous situation. That combination is common, preventable, and far more serious than most people think. Picture this. Your back locks up after a long day. Your knee starts throbbing. Maybe arthritis flares just enough to make stairs feel personal. You do what millions of people do without a second thought. You reach for ibuprofen or naproxen. It feels routine because it is routine. These are over-the-counter drugs, familiar names, household names. They sit in kitchen drawers and bathroom cabinets like ordinary tools. But your kidneys do not grade risk based on whether something required a prescription. They respond to chemistry, blood flow, and stress. That is why anti-inflammatory pain medicines deserve respect, especially if you are older, dehydrated, or taking blood pressure medicines like lisinopril or losartan. The National Kidney Foundation warns that NSAIDs, such as ibuprofen and naproxen, can reduce blood flow to the kidneys and may be particularly risky in older adults, people with high blood pressure, heart disease, or kidney problems, and those who become dehydrated. They advise caution, good hydration, and medical guidance, especially with regular use. Now add one more piece. Many people taking Lisinopril or Losartan are also on a diuretic, a water pill, because controlling blood pressure often takes more than one medication. Put together an ACE inhibitor or ARB, a diuretic, and an NSAID, and you create one of the classic setups for kidney injury, especially if fluid intake is poor or illness is already in the picture. You do not need to memorize the mechanism to respect the pattern. The pattern is what matters. Blood pressure medicine, water loss, anti-inflammatory pain relief, then suddenly dizziness, weakness, or lab results nobody likes. What makes this so frustrating is that it often begins with reasonable choices. Pain relief for aching joints, faithful use of prescribed medication, doing your best to stay active. None of those choices feel reckless. But medicine is full of combinations that become riskier when stacked together, and patients are rarely warned about every stack they might accidentally create on their own. If pain is frequent in your life, the answer is not to suffer in silence. The answer is to discuss safer strategies. For some people, acetaminophen may be a better occasional choice, though it still must be used correctly. For others, topical anti-inflammatory treatments, physical therapy, heat, pacing, bracing, or different prescription approaches may lower risk. What matters is replacing guesswork with a plan. www.kidney.org/news-watch-out-your-kidneys-when-you-use-medicines-pain. And now we need to talk about a symptom so common that many older adults treat it like background noise: dizziness when standing. That brief, wobbly moment when you rise from bed or push yourself off the sofa and the room tilts just enough to make you grab the wall. Most people brush it off. I stood too fast. I am tired. I did not sleep well. Maybe so. But repeated dizziness in someone taking blood pressure medication is not a trivial detail. Both Losartan and Lisinopril can contribute to lightheadedness, and Losartan's patient information explicitly warns that getting up too quickly may cause dizziness, lightheadedness, or fainting, especially early in treatment. The practical advice is simple and old-fashioned because it works. Rise slowly. Sit on the edge of the bed. Let your feet settle on the floor for a moment. Give your circulation a chance to catch up before you demand balance from it. Why does this deserve so much attention? Because in older adults, a few seconds of dizziness can become a fall, and a fall can become a fracture. Once that happens, life can change fast. Recovery may mean lost mobility, lost independence, pain, rehabilitation, and a fear of moving that lingers long after the bone heals. A moment that feels minor can open a major chapter. This is where people get trapped by pride. They do not want to sound fragile. They do not want to overreact. They do not want another medication change. So they say nothing. They simply adapt in secret. They stop carrying laundry downstairs. They avoid getting up at night too quickly. They grip furniture. They normalize near misses until the day one of them is not a near miss. A better response is quieter and braver. Report the pattern. If dizziness persists beyond the first weeks of treatment, if it is worsening, if you feel close to fainting, if you have actually fallen, those details matter. The dose may be too high. The combination may need adjusting. Hydration may be part of the problem. The right answer cannot emerge from information you keep to yourself. The same logic applies during heat waves, long car trips, and days when appetite disappears. The risk does not require dramatic illness. Sometimes it begins with hours of sweating, poor hydration, and a pain pill taken for convenience. Sometimes it begins with a weekend of yard work, followed by a sore back and very little water. By the time the weakness feels serious, the chemistry may have been changing for longer than anyone realizes. That is why prevention here is so plain and so often ignored. Ask before combining routine pain relief with blood pressure drugs, especially if age, dehydration, or kidney concerns are already part of your story. A warning only helps if it arrives before the habit. Once a person has normalized self-medicating with familiar pain relievers, the kidneys are asked to absorb the consequences quietly. They often do, until one day they do not, and that is when routine suddenly becomes memorable for all the wrong reasons. The real danger is familiarity. People trust what sits on a store shelf, and trust can hide risk better than fear ever does when kidneys are already under silent strain daily. And while we are on the subject of information, there is another trap that causes panic, bad decisions, and unnecessary dose changes. It does not begin with a symptom. It begins with a blood pressure monitor, a single number, and the very human urge to react before understanding what that number actually means. Blood pressure has a way of turning sensible people into detectives and gamblers at the same time. One number flashes on a home monitor, and suddenly the mind races. It is too high. It is too low. The medication is failing. I need an extra dose. I should skip tomorrow. I need to call someone right now. That spiral is incredibly common, and it is made worse by one misunderstanding: the belief that blood pressure should behave like a fixed score. It does not. Blood pressure moves constantly. It responds to sleep, stress, pain, temperature, dehydration, movement, caffeine, anxiety, recent conversation, and even the fact that you are measuring it in the first place. That does not make home readings useless. It makes method essential. What matters is not one dramatic number taken in chaos. What matters is the pattern collected under similar conditions over time. medlineplus.gov/ENCY/PatientInstructions/000722.htm. That means measuring with intention. Sit quietly first. Use the same arm. Rest for several minutes. Do not talk during the reading. Do not take it right after rushing around the house. Record it. Repeat it consistently enough to reveal a trend instead of a mood. When patients bring careful logs to appointments, doctors can actually work with the information. When they bring one alarming screenshot from a chaotic morning, the conversation becomes far less useful. medlineplus.gov/ENCY/000722.htm. Here is why that matters so much with medications like Amlodipine, Losartan, and Lisinopril. These are not rescue drugs. They are not meant to be taken emotionally. You do not usually take an extra dose because one reading scared you, and you do not usually skip a dose because one reading looked beautiful. These medicines work through steady presence and consistent pressure control. Panic dosing creates spikes and gaps. Spikes and gaps create confusion, and confusion is fertile ground for avoidable harm. Imagine someone waking after poor sleep, hurrying to the kitchen, arguing with a relative, then checking their blood pressure with cold hands while standing half sideways beside the table. The reading is high. Is the medication failing, or was the measurement meaningless? Now imagine the same person after a hot day with too little water, checking again when lightheaded. The reading is lower than usual. Is the medicine suddenly too strong, or is the body temporarily dried out? Context changes everything. This is where a little discipline can save a lot of anxiety. Choose a method and trust it. Morning and evening if your clinician recommends it. Same chair, same arm, same quiet pause beforehand. Patterns tell the truth that random numbers often hide. But there is another layer people rarely consider, and it may be the most psychologically dangerous one of all. Symptoms do not always line up neatly with readings. Some people feel fine with high blood pressure. Some feel terrible with numbers that are not especially alarming. Some blame every headache on pressure and miss the real cause. Others ignore swelling, cough, fatigue, or dizziness because their machine says everything looks decent today. A monitor is a tool, not a verdict. That is why medication safety is not just about numbers. It is about connecting numbers to context and context to symptoms. If your ankles are swelling on amlodipine, the monitor will not explain that for you. If lisinopril is causing a dry cough, the machine will not reveal the link. If a salt substitute is quietly pushing potassium upward while you take Losartan, the monitor cannot warn you. Blood pressure management is broader than pressure alone. And there is one more reason patterns matter. They protect you from your own memory. Most people remember the reading that frightened them and forget the 10 that were ordinary. They remember the morning they felt awful and ignore the week that came before it. A written log cuts through that bias. It lets both you and your clinician see whether a problem is persistent, occasional, improving, or tied to something specific, like illness, missed meals, poor sleep, or medication timing. Numbers also behave differently when the body is under strain. Pain can push readings up. Dehydration can drag them down. Anxiety can distort both the measurement and your interpretation of it. That is why home monitoring works best as a ritual, not a reflex. Sit down, breathe, rest, measure, write it down. Then step back and look for direction, not drama. Is the average drifting upward over days? Is it lower only when you skip meals? Does dizziness appear after hot weather, poor hydration, or a recent illness? Those are the connections that make a blood pressure log valuable. A careful record turns scattered moments into a story your clinician can interpret, and that story matters more than numbers that frightened you. And now we come to the habit that ties all of this together: autopilot. People stay on it because life is busy, because routines are comforting, because asking questions can feel confrontational, and because nobody wants to imagine that a pill they have taken for a year still holds mysteries. But autopilot is exactly how people miss the early clues. They stop noticing the heaviness in the legs. They explain away the cough. They shrug off the dizziness. They keep taking everything through vomiting, diarrhea, or heat because nobody ever helped them build a sick day plan. They reach for ibuprofen because it is familiar. They buy salt substitute because it sounds heart healthy. They do all the sensible things that become risky only when combined. So let me ask you something more important than whether your blood pressure is controlled today. If your body started sending subtle warnings tonight, would you recognize them for what they are? Or would you explain them away until they grew louder? The answer to that question may matter far more than the next number on your screen, because the most dangerous phase of a medication problem is often the phase where nothing feels urgent yet. And that is exactly where the final lesson begins. The final lesson is this: medication safety is not built in the moment of crisis. It is built before the crisis arrives. It is built in ordinary afternoons, routine follow-ups, grocery aisles, bathroom cabinets, travel bags, and kitchen tables. It is built when you decide that taking a medicine faithfully is not enough by itself. You also need to understand the terrain around it. If you take amlodipine, remember the pattern. Swelling in the feet, ankles, or lower legs can happen. It does not automatically mean heart failure, but it does mean the symptom deserves to be reported and interpreted in context. Dizziness or lightheadedness can happen too, and fainting or a racing irregular heartbeat are not things to dismiss. If you take Lisinopril, remember the split between nuisance and emergency. A dry, persistent cough is a recognized side effect. It may begin late enough to fool you. Swelling of the face, lips, tongue, or throat, trouble breathing, difficulty swallowing, or hoarseness are entirely different. Those demand urgent attention. Also remember that vomiting, diarrhea, sweating, and poor fluid intake can drop pressure further and increase the risk of trouble. If you take Losartan, remember the hidden chemistry. Potassium matters. Salt substitutes containing potassium, potassium supplements, and certain products marketed as healthy can become part of the story. Dizziness on standing may be medication-related, especially early on. Dehydration changes the rules here too, which is why significant vomiting, diarrhea, fever, or inability to drink normally should trigger a sick day conversation you have already planned with your clinician instead of improvising alone. Then there are the 3 practical questions every patient on one of these drugs should know how to ask. First, what side effects are common with my exact medication, and which ones mean I should call right away? Second, what is my sick day plan if I am vomiting, have diarrhea, or cannot keep fluids down? Third, what over-the-counter medicines, supplements, or diet products should I avoid or discuss before using? Those questions sound simple because they are simple. But simple questions often create the biggest difference in safety. There is a deeper reason this matters. Understanding medication changes the emotional experience of illness. When symptoms appear in a body you do not understand, fear fills the gaps. Every swollen ankle becomes a catastrophe. Every cough becomes a mystery. Every dizzy spell becomes a private negotiation between denial and panic. But when you know the likely patterns, you gain something powerful. Not control over everything, nobody gets that, but clarity. And clarity changes behavior. George got part of his life back when he learned his swelling had a likely explanation and a manageable path forward. Margaret got her sleep back when someone connected a months-long cough to the right medication family. Neither story ended with a miracle. They ended with understanding, conversation, and adjustment. That is what safer medicine often looks like. Not drama, not heroics. Just the right connection made before the wrong consequence arrives. The people at highest risk are not always the careless ones. Often they are the reliable ones. The people who never miss a dose. The people who assume obedience and safety are the same thing. The people who tolerate symptoms because they do not want to bother anyone. The people who think a drugstore purchase is too ordinary to mention. The people who keep taking everything during dehydration because consistency sounds wise. The people who trust the routine more than the signals.